short of breath, they're not making urine, they're confused, there's our confusion again. Distended neck veins, always be looking for that as well. Edema, you can see the edema on this person. And they're gonna have a higher wedge, decreased cardiac output, and increased systemic vascular resistance. Okay, last. They're gonna have a great big old heart, and I think I have x-ray pictures after this. We're gonna talk about big old, and blunting of costophrenic angles. I'm gonna teach you what that means in just a minute in the next slide, actually. When we do an echocardiogram, the wall of their heart, whatever's affected, isn't gonna be pumping as well, so wall motion abnormalities, they can be dyskinetic, akinetic, they just don't pump so well, or valves can be a problem as well. Most of these people will have an elevated in their cardiac biomarkers because they're losing cells, maybe not from an MI, but maybe just from this severe lack of oxygen to the heart. And then the BNP can be elevated if it is a congestive heart failure. Okay, this is a normal x-ray. And these things down here, these two little points, are called costophrenic angles. You need to start looking for those. You can see here the silhouette of the heart, and the heart should be a little like half to 2/3 of the whole cavity. So this is a really normal looking cardiac silhouette. So this heart is not overly big, and I can clearly see my costophrenic angles. Costophrenic angles go away when you have congestive heart failure, because congestive heart failure is a dependent thing. So that's why when your patient sits up, why they get orthopnea, because when they sit up, the fluid drains down, and they can recruit more alveolar space to make their oxygen exchange well. So costophrenic angles go away in congestive heart failure. So here is, can you see the cardiac silhouette? It starts about here, and it ends about here. Can you see how big that is? That is a very big heart. That heart should not be that big. The other thing here is, can you see that we call this blunting of costophrenic angles? So you can see that they're there, but they're very cloudy looking. So this is someone that is, well, this person's in ARDS, but this also, the blunting is very typical of congestive heart failure as well. I just liked this picture. Okay, so cardiogenic shock, rule out that they have constrictive pericarditis, which is pretty uncommon. Everything comes with a story. So if your patient comes in and they say, oh, I had non-Hodgkin's lymphoma and I had chest radiation for 2 years, about 20 years ago, you'd think constrictive pericarditis because they probably burned the pericardial sac and now the heart can't expand against it. So things like that come with stories as well. Rupture of an aneurysm, you'll see that on, well, if it's ruptured, they'll be dead. But if it's there and it's expanding, then you can see that on, they do x-ray and then CAT scan, and they would find that as well. Myocardial contusion after trauma used to be really common before we had airbags. Everybody hit the steering wheel. We had one of the things you saw in the cardiac unit all the time was cardiac contusion because everybody hit the steering wheel. They had bruising on their myocardium. Not so common anymore because we have the wonderful airbags that help us as well. All right, so what's the goal is to improve cardiac output and decrease the myocardial VO2, which is the demand. So we want to reduce the amount of demand on the heart, and we want to increase the amount of cardiac output as well. So we want to make sure they have good O2 delivery, so we're going to make sure that their oxygenation is good, do whatever we need to do for that, intubate them, don't intubate them, just keeping their O2 level high. Relieve pain and anxiety, which will relax them, and then inotropic support. So inotrope is that squeeze. Dopamine, digoxin, and milrinone, the three most common. This is not a drip. Dopamine and milrinone are very common drips. And interventional procedure, that means if you're having an MI and it's because of an occlusion, you need to take them to cath lab. So that you're going to do what you need to do to make them better. Put that in as well. So this is from your book, and almost every article like that would argue with this. So I'm going to tell you about it, but even though your book's fairly updated, the best single guide to resuscitation. What are they talking about? They're talking about fluid balance. Do you have too much fluid in your system? Do you have too little? Will you respond to fluid bolus therapy? Will that help you? Will that make you more congestive heart failure, more worse, more overloaded as well? So SVV high is dry. So the world says 14, your book says 13, and between 9 and 12 here is the great gray area, and so if you are dry, you need volume. If you're not dry, then you're gonna need dopamine or milrinone, is what this is saying as well. Now, here's an interesting one that I want you to think about for just a minute, because this is a really good thing, and it's a real practical piece of advice that you can use for the rest of your career. If you have somebody who has a low cardiac output, so they both have low cardiac output, but in this one, they have a normal or a high blood pressure. In this one, you're gonna use dobutamine, because dobutamine won't affect the blood pressure. In fact, it causes has a little beta in it and will cause a little bit of hypotension. But if you have a low cardiac output and a low blood pressure, you're going to use dopamine because it also is a vasoconstrictor. It has alpha in it. Now that alpha is going to make the heart work harder. It's going to increase the heart rate, and that's a bad thing. But if you don't have a blood pressure, you're probably going to need to choose the dopamine over the dobutamine. And this little piece of information right here is a gem that you're going to be using in your career, because this is something we do all the time and how we choose what we use. Okay, before we get distributed, let's take a 10-minute break.